RetinaRounds, episode number 85. To operate or not to operate. This patient has a history of advanced diabetic retinopathy with poor vision in both eyes. This left eye has undergone TRD repair at an outside hospital and has significant residual emulsified oil as well as a chronic full-thickness macular hole. And would you operate on this patient? And if so, what clinical and imaging data would you use to guide your decision-making? These are the questions facing first-year UCLA vitreoretinal fellow Dr. Prashant Tailor. Let's see how he and his attending managed this patient, and at the end we'll look closer at the OCT findings that can help guide you when you're faced with this question. Thank you, Dr. Tailor, for sharing this case. This patient is a 40-year-old type 1 diabetic female with a history of TRD repair performed in both eyes at an outside hospital. The left eye underwent initial surgery in 2008 and subsequent oil removal in 2012. She's transferred care and presents with significant emulsified oil in the anterior chamber as well as a full-thickness macular hole. Her vision is 20/400. Here's the pre-op OCT. You can see that there is a thickened membrane nasally that likely represents residual posterior hyaloid. This membrane is exerting traction on the nasal aspect of the macular hole. The hole measures about 800 microns in minimum linear diameter. After extensive counseling with the patient, they have elected to proceed with surgery to remove the emulsified oil and attempt to close the macular hole. Now, Dr. Tailor starts by washing out the emulsified oil in the anterior chamber. Next, an air fluid exchange is performed to remove emulsified oil in the posterior segment. Some small residual PFL bubbles are also removed. Using forceps, the residual fibrosis over the supratemporal arcade is elevated. The membrane is then segmented from the optic nerve, and then it's peeled following the course of the supratemporal arcade and away from the optic nerve. A partial air fluid exchange is performed, and tissue blue is instilled over the posterior pole to stain the ILM. Now ILM peeling is carried out using the pinch and peel technique. An edge of the ILM flap is extended in a circumferential pattern. Now you'll notice as the ILM flap is fashioned superiorly that it appears to be tightly adherent to the macula and is easily friable. Now this is not an uncommon issue when peeling ILM in diabetic patients, but it's likely exacerbated in this patient given the prior surgery and use of silicone oil. Now once the ILM flap has been extended 360 degrees, the multiple leaflets are then inverted over the macular hole. Here you can see the use of intraoperative OCT, which shows that the ILM flap is over or covering the macular hole. Now a very slow, complete air fluid exchange is performed so as to not to disrupt the ILM flap. 20% SF6 gas is implanted into the eye, the trocars are removed, and the wounds are sewn shut. Now here's a patient's postoperative OCT. You can see that the macular hole is closed. This appears to be a type 2 closure with a plug of ILM and gliotic tissue bridging the edges of the macular hole. The patient's visual acuity has improved at post-op month 1 to 2150. Now given that the patient's fellow eye is 2400, this patient is very happy even with the modest vision improvement. Going back to our question about whether or not to operate on this eye, there are a number of factors to consider. Now this patient was primarily scheduled for surgery to remove the emulsified oil, but what about the macular hole? Without knowledge of this patient's outcome, preoperatively one can make the argument that the vision is limited by macular ischemia, and given that this is a chronic macular hole, surgical intervention may not be warranted. On the other hand, this patient is young, has very poor vision in the fellow eye, and even a small functional improvement may not only benefit the patient now, but closure may help to prevent further vision loss down the road. Now, what about the OCT features? We have discussed these previously in episode 55, but let's review it again for this case. The minimum linear diameter of this hole is about 800 microns, making it an extra large macular hole, and making an ILM flap, as Dr. Tailor decided to do, a good primary surgical intervention. The macular hole index, which is the ratio of the height of the macular hole to the base linear diameter, is less than 0.5, which decreases the likelihood of closure. Now, conversely, there is a VMT and an elevated cuff at the margin of the macular hole, making closure more likely. The edge is not edematous, which may be the case in very long-standing macular holes, and there is modest disorganization of the retinal inner layers, suggesting macular ischemia, thus somewhat limiting the patient's vision potential. Recently, a new morphologic staging system for macular holes has been proposed and was published recently in Ophthalmology Retina. When looking at the OCT features at the margin of the macular hole, the authors categorized holes as stage A, where the bacillary layers are intact, including the ELM, ellipsoid zone, and interdigitation zone. These holes carry a favorable prognosis for closure and vision. Stage B holes demonstrate thickening of the ellipsoid zone and an intact ELM. Stage C holes show patchy disruption of the photoreceptor layer, and stage D holes show near or total loss of photoreceptors with an attenuated ELM. Now, higher stage holes, particularly stage D holes, tend to have a worse visual prognosis. The OCT of the patient presented in this case is shown to the right, and you can see that this is largely a stage C hole, although there are elements of a stage D hole on the temporal edge of the hole. Taken together, these findings indicate a moderate likelihood of hole closure and a low to moderate likelihood of vision gain. Unfortunately, this patient achieved hole closure and a modest improvement in visual function, but given the patient's age and poor fellow eye vision, even small gains or a higher likelihood of long-term stability in vision is a win. As always, detailed counseling with the patient to set reasonable expectations for outcomes is critical when deciding whether or not to operate. Thank you, Dr. Taylor, for sharing this case and for giving us an opportunity to learn more about the management of chronic macular holes. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.